Yeah, and this should be available on YouTube if any of you ever want to go back, just to make sure, like, just to see anything if we missed or anything.
So Momna, do you mind, just for the purpose of recording, do you mind just quickly reintroducing yourself briefly?
Okay, yeah, I'll start again. So hi, I'm Momna, the AFP's in East Midlands, currently based in Kettering, went to Brighton Medical School, and that's a quick intro. Interested in cardiothoracic surgery. My email's there if you have any questions after the talk, if you wanted to get in touch.
And hi everyone, my name is Alireza Sherafat. I'm a UCLan graduate. I'm doing SFP in East Midlands, and I'm interested in surgery. We have prepared these slides with Momna. Feel free to ask us questions. You can see our emails down there. Yes. So
yeah, I think there's only 6 of them. So if you have any questions, literally just pop them in the chat, or feel free to interrupt us, because we're not scary. We'd like to think we're not. So this session in particular, we're just going to go through a quick structure of a good way to approach a research paper, because sometimes when you look at it, it looks quite scary and it's quite intense. We're going to go through how to clinically appraise an abstract or a paper, because different deaneries will give you different. So you might either get just an abstract like half an hour before you're supposed to have your interview, or you might get a full paper. If they give you a full paper, they usually give it to you the day before the interview. So we're currently in LNR. So LNR likes to give you a whole paper on the day before, so you can kind of have the whole 24 hours to go through it, appraise it, ask questions, and then present before you discuss it with researchers. Alireza, do you think we could go to the next slide?
Yeah.
Is that okay? It's still on that slide. Oh yeah, awesome. So since COVID, the interviews have been on Teams, which I think is brilliant because it saves you so much time having to travel, especially, for example, if you had like your AFP interview in Scotland and you're like down south in Brighton, it saves you so much time, but also it gives you a really good opportunity to practice. So because we know that it's going to be on Teams, it's really good for you to just record yourself practicing. And then when you do practice, make sure that you're not looking at the screen itself, but look at the camera just to make sure you have eye contact. You're allowed to make as many notes as you want. Make sure you kind of color code it, because sometimes it's stressful when you're flicking through like tons and tons of notes. And in the actual interviews, you might have to wait quite a bit. So I think in my London one, I literally waited for like 3-4 hours, but between when they showed me the abstract and the clinical scenarios to when I actually had my interview. So just make sure you bring like drinks or snacks if you want to. In terms of when you actually approach an academic station where you have to critically appraise something, the best thing is to make sure that you have a structured approach to it, so it doesn't seem like that you're all over the place. So and then PICO itself is not a way to critically appraise a paper. It's just a way to quickly summarize it. And the final tip that we had is just make sure that you're confident, fake it till you make it.
Yeah, absolutely. That's a very important point, as Momna raised. So try to have a smiley face and try to make sure that you sound confident. Even if you're not confident, basically you have a general understanding of academic topics, unless you are not prepared. So basically try to sound confident and try to approach them with a smiley face.
Mm-hmm. Even if you're like shitting your pants, like, it doesn't matter, just right.
Okay.
Question. Okay, so I wanted to kind of go through the article that we had to do for our interview last year. So it is the recovery trial. Is quite big, you might know about it. So this one in particular is use of dexamethasone in hospitalized patients with COVID. What we've done is we've put a QR code, and it's on all the slides. At any point you wanted to look at the whole paper or just like the abstract, you can do that at any point.
And
so,
just a disclaimer, this was just something that happened last year. They may change that. They've most likely changed the paper this year. And in any way, we are not involved with interviews, and we don't know what's going to be in the interviews this year or in the future. So just use this as an example, and this paper is freely available online.
Yeah, so I think the reason why they use this one is because it's such a big trial last year, especially with the COVID and things. Usually they don't tend to use, because this one itself is a cohort, so they tend to use more RCTs because they're quite easier to go into. But this paper was so huge that was what for our interviews last year. So Alireza, if you click, and I think you should give us a little introduction. So Just kind of reading through it. So reading through the background. So when you look at it, I would, if you were just given an abstract before you critically appraise it, I would just read the whole thing in one go before I start analyzing it. So for this one itself, COVID-19, it says associated with diffuse lung damage, glucocorticoids may modulate inflammation, mediated lung injury, and therefore reduce progression to respiratory failure and death. So then just read the methods. So in this controlled open label trial, comparing a range of possible treatments in patients who were hospitalized with COVID-19, we randomly assigned patients to receive oral or IV DEX, 6 mg once daily for up to 10 days, receive usual care alone. The primary outcome was 28-day mortality, and hence we report the preliminary results of this comparison. I think if you click, it will give you result. Okay, so now these are all the results. Feel free to take a minute and read them, but it's quite a lot of numbers. Okay, and then we can just click to the conclusion. Okay, so, and then the conclusion is, in patients hospitalized with COVID-19, the use of DEX resulted in lower 28-day mortality amongst those who were receiving either NIV or oxygen alone at randomization, but not amongst those who received no respiratory support. And then you can see that who funded it. So it was funded by the MRC and the National Institute of Health Research. And then you can see at the end that it's also a registered trial. So you read the whole abstract, and now you're just thinking, oh, how am I going to actually break it down? So the way that it was a really good structure to have when you're kind of trying to critically appraise, which we got taught last year, is this mnemonic. So it's QR, PIC, Peacock, Rambus, RP, FEC. So the mnemonic that it stands for, so QR is, so we're going to go through each of these individually for this paper, but just kind of going through what it stands for. So QR is question and relevance, like what are they actually asking? What is their clinical question and how is it really relevant to the population? Peacock is basically just a summary of the actual study. So population, what intervention did they use? Was there a control? What outcomes were they? So primary, secondary outcomes, and then the key findings. So what did this trial actually report? Rhombus is a way just to look at the internal validity. So internal validity is, are the results of the study actually valid, or are they because of bias? And the way you can look at it is you look at the recruitment. So how were the participants actually recruited? So in this way, it just said everyone with who was admitted to hospital. So what was the process of actually recruiting them to it? Did they volunteer? Were they just allocated? Cohort studies, you should just take the data for them. But if it was an RCT, did they volunteer? What was the way? Allocation is were they randomly allocated, or did someone manually do it? Was it based on how unwell they were, maintenance, and then baseline characteristics, outcomes. So what outcomes were there? So primary, secondary, we'll go through all of that and statistical analysis. RP is a way that you can kind of break down external validity, which means that how are your results generalizable to the population? And you can look at that with the resources. So the treatment that they used, it is so expensive that more hospitals can't even afford. Or is it something that's readily available? And then population. So what population did they necessarily target? Or was it just the inclusion and exclusion criteria just so strict that it only applies to a certain demographic? And then the last one is FEC. So that's funding. So who actually funded the project? And did that actually impact on the results of it? E is for ethics. We can go through that later, and then C is just to conclude the whole thing. And the way I did it is because usually when they ask you, they'll ask you for the strengths and the weaknesses. So when I would structure my answer, I would just put, oh, external validity, these are the strengths on one side and these are weaknesses on the other side. Alireza, I don't know if you want to.
Yes, absolutely. So very good introduction and very good structure to basically put in your answer. Just make sure when you are preparing for SFP interview, just get papers from, sometimes abstract, sometimes full text papers from PubMed, and try to critically appraise it in this order. You can develop your own way of presenting that. Usually you will be given 2 to 3 minutes to present the abstract, and they usually tell you to present the main findings. And when they tell you the main finding, just don't go like just and tell them the conclusion only. Do this properly, use peacock model, and use a framework to basically structure answer. They're not looking at what was the conclusion, what was like one sentence, the message of the paper. No, that's not the key findings. So they might phrase it differently, and sometimes you can clarify your understanding if you are not sure what they mean really. If they're like looking for a 30-second answer, you shouldn't give a 4 minutes answer, and vice versa. You can just clarify your understanding. You can ask the interviewer, would you like me to critically appraise the paper? Would you like me to go through the paper in terms of Pico model, or you just want me to give the main findings? You can, but usually they're looking for a framework and a structure to critically appraise a paper. Yeah, that's very good. I'll go next slide.
Yeah, and I think Alireza raised a really good point about not just saying the conclusion, because a lot of the times researchers, and I know like a lot of people I've known are guilty of this, they'll put what they want you to hear in the conclusion and not necessarily say the key stuff. So just by mentioning other things, you kind of show that, oh, I've read the paper, and A and B don't add up, for example. So just going through the framework that we went through. So QR is question and relevance. So the recovery trial is on this pyramid of hierarchy of evidence. So kind of at the bottom, you have editorials, and I just go up. They get the bias that they have reduces. So then above it, you would get case reports, and then it's cross-sectional studies, then it's case control, cohort, RCTs, and then the top would be systematic reviews and meta-analysis of RCTs that has pulled like loads and loads of data. So it's really good when you show that you have an understanding on it. So in this case, I would just say, oh, so I know this is a cohort study. And then how is that relevant to the now and here? So this looked at patients who were hospitalized with COVID-19 in the middle of the pandemic. So that's quite relevant to the here and now, because COVID has a really high mortality rate, and they're looking especially if giving someone dexamethasone is going to help with that mortality. And patients who survive COVID don't necessarily have the best quality of adjusted life years as well, and they can get things like long COVID. So you're thinking, oh, this clinical question that they're asking is quite relevant. Which was the rest of the slides. Mm-hmm. Okay, and right. So this is a little summary of the paper. So we said Peacock is just P is population. So how many patients were hospitalized with COVID-19 across the UK. Intervention was dexamethasone, 6 mg, once daily, either orally or IV for 10 days against usual care. And then the outcomes that they measured was the primary outcome that they measured were 28-day mortality. And the key finding that they had was that there was a reduction in the incidence of death, especially with the patients who had an increased oxygen requirement. So the patients, most in patients who had NIV, but also those who required oxygen. So just to kind of summarize that, I would just say something along the lines of, so this is a pragmatic, controlled, open label cohort study that evaluates the impact of receiving dexamethasone in patients who are hospitalized with COVID in the UK in comparison to usual care. And then the key finding would be that the authors suggest that in patients with oxygen requirements, the use of dexamethasone results in reduction of mortality. Does that kind of make sense so far?
So yes, that's very good way of summarizing. And also, like in terms of outcomes, usually different types of therapist trials, course studies have like more than one outcome that they're going to measure. So there's usually one primary outcome, which is the most important thing. So in this case, mortality. There could be other secondary outcomes which you could potentially need to talk about if you were given the full paper, or if you were given the abstract. Sometimes they might mention that even in the abstract as well. So secondary outcomes are like other important factors you would consider if you're introducing an intervention or a procedure or drug which could be potentially beneficial. So it can be like length of hospital stay, it can be about the cost of treatment, it can be about other factors. So those are secondary outcomes, and primary outcomes is usually sometimes mortality in this case. And in terms of key findings, you can mention both key findings of basically primary outcomes in terms of primary outcomes and secondary outcomes, how the paper addressed those. So you can discuss that as well if you have secondary outcomes. Yeah.
Yes. And then sometimes it's good to critically analyze to see if those relevant outcomes are relevant as well. Because sometimes if they don't get a significant enough result, they'll do something called a composite, which is when they'll combine loads of outcomes and report it like that. So the next thing that you want to look at is the internal validity of a paper. And the mnemonic for that is thrombus. So just looking at the recruitment. So we said, how are these patients actually recruited? So from the abstract that we know is consecutive, so it's within a certain period of time and everyone's who's submitted was kind of registered for it. It's multi-centered. I think it was like over 170 trusts. It's tertiary, so it's just in hospital. And you want to see stuff as an allocation. So they said that it was randomized, but they didn't necessarily say how it was randomized. Was there a computer? What was the method of it? And were the patients actually blinded? So with blinding, you want to see if obviously if it's single, double, or triple. So single would be just the patients, double would be patients and the clinicians treating them, and the triple would be everyone's blinded, including the person who's crunching the numbers as well. Then you want to look at the maintenance, the kind of how many patients, and it's really important that you look at attrition bias as well. So how many patients dropped out from the trial? So it could be like, for example, not necessarily this, but if in another trial, patients just didn't receive good quality of care in one arm and they just dropped out. But then that means that everyone who's dropped out has not necessarily received the good quality of care. So then the results will be skewed towards one side, but that's only because the people on the other side have dropped out. And usually in a trial, you want a dropout rate of less than 20%. So then you can preserve the power of the whole paper. And then the next thing you want to look at is outcomes, but we're going to go through that, the mnemonic Trito, and then last is statistics. Wait, I feel like I forgot baseline in there. I did. Yeah, so with baseline, so you want to look at the baseline characteristics. So I appreciate sometimes you won't get that table in an abstract, but the baseline characteristic table is quite a good way to see if the patients are well balanced in both groups and if your randomization has actually worked. So if the age of the patients is similar and there's no significant p-values and baseline like comorbidities and things like that. So for example, in this case, it's really important that you look at this table, because is it that the patients who have more comorbidities are more likely to require oxygen requirements? And then perhaps that's why they have the results are more skewed this way. So you can see from that table that there's no significant differences in the patients in different groups.
And if you want to critically appraise any paper just before like looking at, there's almost always a table of characteristics of patients who were studied, including the demographic information. Always keep a list of demographic information, important ones in your minds, like age, sex, ethnicity. These are important ones. Like if one of these was missing from the paper, hopefully age and sex should be there, but if ethnicity was not missing, like there was no mention of what sort of proportion of white and non-white in fact population were included, or other like chronic diseases, there was no information on that, just be a bit suspicious and raise it as a concerning like way of, it could be biased. So basically try to keep an eye on those sort of demographics. There should be information on them to basically make sure there's no basic confounding factors involved in the study. So basically always mention that, because it needs to be balanced out in terms of confound. If you have had effective randomization, the effect of differences should be minimized, and there should almost be equal number of in the basically different population in terms of ethnicity, age, and sex in both intervention and control groups if you have had good randomization. So yeah, always make sure you mention those things if any of those are missing.
Especially with COVID, because the data showed that COVID mostly impacts people of color worse. They have worse outcomes than other people. So yeah, like Alireza said, it's quite important that you look for that. If you do get a whole paper and you don't find that information, sometimes they hide it away in the supplementary data. So I would just have a peek there just to show you that you kind of went and you've had a look at everything related to that paper. So yeah, so the way that I looked at outcomes was with the mnemonic TRADO. So T is type. So what kind of outcome is it? So like Alireza said before, so there's always a primary outcome, which is the main goal. So in this abstract, they just said the primary outcome, but they will have secondary outcomes, which is other things that they will also look at to see if dexamethasone made a difference for that. And then you want to look at outcomes if they're subjective or they're objective. So is it something that's fixed that won't change, or if it's something that's more like what the patient felt, like quality of life would be more subjective. Whereas in this paper, it's quite an objective point. You either die or you don't. So like the mortality is quite fixed. And then you could say if the outcome is clinical, if it's composite is when you combine a few of the outcomes together. And then surrogate is more biomarker outcomes. So things like blood pressure and things like that. And then you could just say relevance. So the relevance of that outcome to the clinical questions. So again, with this outcome, it was 28-day mortality, which is quite relevant when it comes to COVID, because initially when the pandemic started, that was the thing that they were most worried about, because so many people were passing away, unfortunately, when they were getting COVID. Next thing you'd like to look at is if the trial, sorry, I know it says RCT, but is the trial, it says self-registered, and it's really, really good if it is, because that means that they've published a whole protocol and they can't really deviate away from that protocol because they've set their outcomes, they've set their whole methods, and they can't really deviate away from them. And then the next thing is duration. So how long would the patients followed up and was it really appropriate? So in this case, 28 more day mortality is good, but then it'll be good to like kind of go above and beyond that and see if that impacts as well. The next thing is observation bias. So not necessarily in this case because it's 28-day mortality, so that won't be really affected. But in some case, if you know that someone's watching, you tend to do things that you wouldn't otherwise do. So let's say like if it's a study about, or if it's an RCT, something to do with nutrition or something, and you know that you're going to be followed up like every so often, you're more likely to stick to it, which people might perhaps not do in a general everyday life. So then that adds kind of observation that, so you kind of do things that you wouldn't necessarily do in a normal setting just because you're being followed up every so often, or you just know that someone's watching you. And then always be cynical. So like, what are they actually not measuring, which might be important when you look at outcomes? And then how many of those outcomes are also safety outcomes? And that's all I have to say. Alireza, do you want to?
Yeah, brilliant. Yeah, absolutely. You need to look at what sort of primary and secondary outcome they first initially basically decided to investigate, and if they're meeting those or not. And that can be directly related to the internal validity of the paper. Have they answered the question they initially raised? So that's essentially the message. And you can go through it depends. It really depends if you have the full paper or the abstract. I think, to be honest, a lot of places do full paper, so basically you should be able to address that question. Yeah.
Yeah. Oh yeah, that's it. I think it's only a handful that will give you an abstract. Like London will give you abstract, but most places outside London will give you a whole paper, and you've got time to go through it as well. These are kind of, so I made a table of all the definition for SATs that I would recommend that you just learn, because they will 100% ask you. So they'll be like, okay, so the outcome is, let's say, odds ratio, what is that? Or then they'll be like, oh, right, okay, so you're saying something about placebo, but what does that really mean? And then, and you might say, for example, oh, this is the registered protocol and they went by intention to treat. Then they'll be like, okay, so what does that mean? So they will ask you these questions. So make sure that you know your definitions for all of them, because they will 100% ask you. Because I think in our interview last year, we got asked what a p-value was, what confidence interval was. And then one more thing I remember they asked me definition of, I can't remember what it was, but they will 100% ask you. So it's just better that you just have a quick little, because it's easy marks, isn't it?
Yeah.
So if you just learn it and then forget it.
Yeah, in addition to asking like general qualitative assessment of papers, they will also some specific like tick box questions like multiple choice or like single answer questions. So sometimes they might ask you about levels of evidence. Sometimes they might ask you just that pyramid that we showed at the beginning. Also, just they might ask you about what's the difference between odds ratio or relative risk, so or hazard ratio. So just try to be very succinct in your explanations, and also try to memorize those or learn those in fact definitions before going to for an interview. Yeah, absolutely.
It's also the same for like the tables that they make as well. So then they might like look at the consult patient flow diagram and be like, what is that? Or they might give you like if there's a meta-analysis, be like, give you a forest plot and be like, what is that called? Like I remember being asked that in both of my interviews, actually. They were like, what is that called? And they just want to test you to see like, oh, are you actually interested and do you know your stuff? But this is all you can learn in a day. But yeah. Right. Next, so this is kind of my rhombo structure for it. So what I wrote for this is the recovery trial is a consecutive multi-central trial in the UK involving 176 centers. So all participants were randomized, although we're not sure exactly how. It does reduce selection bias and the effect of confounding factors on a result. However, it makes it difficult for us to maintain a rigid study protocol. I would like to check the inclusion exclusion criteria and then the method of randomization. And then this is a registered trial, which reduces the risk of data dragging. And then the outcome is 28-day mortality, which is relevant given the high mortality associated with COVID. So kind of I've done all of that. And then the next bit, sorry, I'm just reading what I wrote, but the next, oh, Alireza, I don't know if you can. Yeah. And then the primary endpoint was a rate ratio, sorry about the typo, which reduces which showed the incidence of death was lower in patients who received dexamethasone in comparison to usual care. So the patient on NIV, so non-invasive ventilation, benefited the most, with a reduction in incidence being 36%, and the confidence interval did not pass 1. So it's quite important that you show that, oh, I've looked at the stats, but then I've also looked at the p-value and I've also looked at the confidence interval, and this is what that means. So it said the confidence interval did not pass 1, which means the results are significant. However, there was no p-values in the actual abstract. So I would, and then also I would like to check if the statistical analysis that they did was intention to treat or as per protocol. Does everyone know what that means, like intention to treat or as per protocol analysis?
You can unmute yourself and talk, please. Anyone?
There's only 8 of us. You can type in the chat.
Or you can talk, yeah.
Or we can tell you, to be fair. So intention to treat is basically if someone has already been allocated to a specific group. So in this case, if they were allocated to usual care and then further on they got really unwell and then you gave them dexamethasone, they will still be categorized as the first group that they were allocated to, which is usual care. So their outcome will still be on that. So that is intention to treat. So you're treating them as you intended to treat them when they joined the trial, even if they later on moved group or dropped out. Per protocol analysis is the analysis that they already predefined in the protocol, which you can find, and then they kind of stuck by it. And it's quite important that you know which one they went with. Okay, so that's internal validity. So the next is external validity. So like we said, external validity just means, are your results generalizable to the general population? So the mnemonic for that is RP resource availability. So you could say something like, in this case, they use dexamethasone that's quite readily available, quite cheap, easily you can get in any hospital in the NHS. So it's quite an easy intervention that you can make. With P population, so you just kind of look at the population and see if that population is representative of the population that you intend to treat, or was the exclusion and inclusion criteria way too strict? So sometimes in RCTs, they're really, really good because you've got a specific group and you can compare that to a control, but then that's the downfall of it as well. So it's too specific. And then outside that, those results might not be generalizable to any single patient. So with a population, like Alireza said before, you can look at the age, the gender, the BMI, height, ethnicity, the lifestyle of the patient. So is there a bias against older people or people who have comorbidities? Are the patients in this trial, they just not as unwell as the patient that you would see in who walks through the hospital? Are they more or less unwell? And then are you giving the same level of attention to these patients that you would in general life as well, or is it too much? And then you can look at other factors that might impact someone as well, like smoking alcohol, other drugs, other yeah. And then what did they actually compare it to? So was it placebo that they compared it to, which a lot of the trials will do, or they compare it to gold standard? Because that's ideally what you want to do, is compare your treatment to gold standard. Because if it's placebo, then it's just comparing against nothing, isn't it? And then just look at, yeah, that's it. That's all I've got to say.
Also, you can consider like external validity. If that particular paper was done like in a country that has a different demographic population to UK, for example, you might be doing an interview, let's say in West Midlands, and there's a professor from Birmingham who ask you about, they can ask you some specific questions about the paper after you presented that as well, by the way. So they might ask you, is the outcome of this paper likely to change your clinical practice? And that's quite a common question that you would come across. And it's an important question because you are first a clinician, then you are an academic clinician. So it's important to use your academic knowledge in your day-to-day clinical practice as well. So you can argue that that population in Iceland probably they're quite different to the population that you see in Birmingham due to certain ethnic groups that may be more present in Birmingham compared to Iceland, and that's the valid conclusion. And they would like to see that. Basically, first of all, it tells them that you are an academic clinician. You can interpret data and you can use that in your clinical practice. And second thing, they are aware that you have done your homework. You have basically studied about the population, the local population of the area that you would like to work there. So it's quite useful to have an idea of the population that you're going to be treating as a doctor in that area before applying.
Yeah, and then usually they love asking that question. Ireza's right, and usually if they give you an RCT, the thing that you would say is like one paper wouldn't necessarily change your clinical like practice. Like one paper wouldn't. You need multiple RCTs, you need systematic reviews, you need meta-analysis. So always be, yeah. So what I mean, obviously the recovery trial changed a lot, but usually they'll give you an RCT and you just have to be like one paper wouldn't necessarily change my clinical like practice. But
yeah, absolutely, that's a very valid response to that the common question. Or you can even argue that further and you can take it to a next level. So in cases of like emergencies, like during COVID, you know, it usually takes months to years to develop a nice guidance, but during COVID a nice guidance was being developed overnight. So like every couple of days there was a new nice guidance, and they were developing that, like I think they were calling that a specific category. I can't remember what exactly was it, but it was like a type of like an urgent emergency sort of guidance for now at the moment. Currently it might change in the future. So you can add that argument as well if you get any COVID related paper in your interview. So it's quite a valid point to be discussed as well.
Yeah, and that's just me writing the external validity, but we've already talked about that.
Okay, so we have another paper, second paper. It's a retrospective study. So title is Prolonged in Hospital Time to Appendectomy. From that name, from appendectomy, you can say is from the US, is associated with increased complicated appendicitis in children. So it is from Annals of Surgery. I'm sure a lot of you may have heard of Annals of Surgery. Is one of the very well-respected surgical journals that we have around the world. So this paper was published quite recently, and you have the objectives. You can have a read through that. And the summary, background data, and the methods. So just familiarize yourself. Ideally, within a minute or two, you should be able to have a read through that. Just give me a second. I'll just have a quick call. Sorry for that. Yeah, so then we have the results. And we have conclusions as well. So from that abstract alone, you already know that this paper is to do with appendicitis, and the objectives is to examine the association between prolonged in-hospital time to appendectomy or appendicectomy, as we call it in the UK, and the risk of complicated appendicitis. And the country of a study is USA, and the journal is Annals of Surgery. So it's the most cited surgical journal, impact factor of 13.787. And the type of a study as well is a retrospective study, and they reviewed records from the American College of Surgeons. So it was a database, basically record review paper. So, and then they had a targeted appendicectomy database from 2016 to 2018. And in terms of primary versus secondary outcomes, the primary outcome was operative findings of complicated appendicitis, and secondary outcomes were 30-day complications and resource utilization. So that is what you have as primary and secondary outcomes, and you have got that reference as well. So in terms of PICO model or PICOC model, so you have the population as patients who underwent appendectomy within 24 hours of hospital presentation. So that initially tells you the inclusion exclusion criteria. You can name it different terms. It's up to your choice how you want to present it. And then PICO model, you don't necessarily have to follow that, but it's a good framework. It's a good structure to follow. And in terms of intervention, appendicectomy or appendectomy was the intervention. And in terms of comparison, early versus late appendicectomy. So they classified early appendicectomy as appendicectomy within the first 16 hours, and anything above that was the late one, so up to 24 hours, so 16 to 24 hours. And then in terms of outcomes, surgical complications were in fact amongst the primary outcomes. And in terms of key message, basically avoid delayed appendicectomy whenever possible. So anything above 16 hours should ideally be avoided to reduce complications. And in terms of sample size, you have the sample size, but just remember, this is the data from the abstract. If you go to the main paper, if you are provided with the main paper, it can slightly be different, because some patients usually drop out of the study due to various reasons. They may no longer be keen to continue with the study. Some people may withdraw their consent to be included in the research, or they might have missing data, or like failure to record the data, or IT issues, and then missing data, loads of reasons. So usually that is different to the number of patients who were included in the final analysis. Just make sure it's usually 5 to 10% difference. So just if you were provided with a full paper, just make sure you quote that number as well. Is there anything else you would like to add, Momna? Yeah, you're on mute. You're on mute.
Sorry, that's why I would look at the patient flow console diagram, because that gives a really good summary of how many patients were actually recruited, how many do you have now, and at what point did they start dropping off? Because if a lot of patients, like Alireza said, are dropping off at a certain point, you could be a little bit more cynical and be like, what was going on there? And now they're not included in the final analysis. Why would that be?
Absolutely, yeah. And usually it's either second or third figure in such a paper. So just make sure you review as many papers as you can potentially access. And then you can familiarize your eyes, because just as I was doing a Cochrane review with a team of basically Cochrane reviewers at my previous university. So they were doing loads. We were doing loads of like in fact reviews of literature reviews and in fact RCTs. But potentially after a couple of papers you have looked at, you can quickly find where that figure is, where that in fact flow chart is, or consort diagram. So just make sure you familiarize yourself, your eyes, with like seeing many of those. So in terms of the next slide, we have the reference, and yeah, so we have references for both studies that we use, that just as an example in this study, in this session, and feel free to refer to SORN website and Medal for the recordings. I believe these recordings will be available on YouTube as well. And in terms of next session, we have already advertised that on Instagram and other social media pages. It's going to be 24th of October, and the third one is going to be on the 31st, I believe 30th or 31st. So we have a feedback form. So I'm just going to stop the recording now, and then you guys can ask questions and stop share and
Literally ask anything.